Today we are lucky enough to have Dr. Lori Montgomery to give us a presentation. Dr. Montgomery is a family physician with a fellowship training in pain management, including headache, neuromuscular pain, pelvic pain, and palliative care. Her clinical work is in the Alberta Health Services Calgary Pain Program, where she sees patients with headache and neuromuscular programs, together with a large multidisciplinary outpatient team. She consults with the chronic pain consultant service and at Calgary's 4 adult acute centers, and supports primary care network pain teams in community. She is community integration medical lead under the AHS Calgary's own portfolio of community care, community, rural, and continuing care. She's a member of the Southern Alberta Primary Care Research Network and a clinical associate professor in the departments of family medicine and anesthesiology, perioperative, and pain management at the University of Calgary, and is involved in teaching at the undergraduate, postgraduate, and CPD level. So welcome. I know we've heard from you already, but we'd like to welcome you to give us the presentation today, and it's The Inherited Patient on Opioids, Pearls for Practice.
Okay. Thank you. So yes, I know lots of you people, and let me just tell you that at least 4 of you have heard versions of this presentation other places, and I will not take it personally if you go away and do something fun like watch Star Wars GIFs in honor of May the 4th. Or whatever you need to do, because you've heard this before. So in terms of disclosures, Leah mentioned off the top that I will be getting an honorarium for this session. Most of my, thank you, Christelle, like you especially, Christelle, could teach this session. So get honoraria for teaching from a number of organizations. The only other thing to mention is that I do have a small grant from the Hotchkiss Brain Institute, which is part of the University of Calgary, for a clinical trial on a medication for opioid withdrawal, but I'm specifically not going to be talking about that at all today. Next slide. So I'm trying to keep learning objectives fairly manageable because we really only have a brief time here. I'm going to try and steer you in the direction of some other resources if you want to dig into this a little bit more. But basically, the bottom line is if you take nothing else away from the session, I want you to feel confident working with a patient who's on chronic opioid therapy. So if you are a family physician taking them on, if you are a member of the multidisciplinary team, feel confident that what you're telling the patient about opioids is the same as they're hearing from the rest of their team. And then often there is a question about when you're taking on or starting to work with somebody who's on opioids, are you going to talk about tapering? And if so, when and how, and what does that look like? So I'll try to give you just sort of a quick and dirty overview of that. And then again, steer you in the direction of useful things. Next slide. So I wanted to start out with a case which hopefully will resonate as being fairly familiar to you. So this would be Robin, new to your practice, has just married a patient who's been a patient of yours for many years. And so you agreed with their begging and pleading that you would take the patient on. 50-year-old with chronic low back pain that's kind of been intermittent off and on for a long time. But for about 11 years ago, there was a motor vehicle collision that caused a flare of pain. And since then, Robin's been taking opioids. They're currently taking hydromorphone immediate release, 12 milligrams 4 times a day, which might immediately strike you as not the ideal strategy. And you're starting to have sort of spidey sense greebly feelings about this case. And Robin's previous family doctor retired suddenly because of health problems, and Robin has nobody to prescribe their opioid medication. So the question is, do you accept Robin as a patient? So this is, perhaps many of you will, by virtue of the fact that you're at this session, would be likely to say yes. But I'm curious, maybe just pop in the chat or unmute and tell me, what do you think might be the reasons why people would not want to take Robin on as a patient? Worry about the CPSA. Thank you, Kathy. That is often the #1 reason why people don't want to take on this patient. Fear of overprescribing, yeah, like am I doing the wrong thing? So not necessarily just the regulatory issue, but am I taking on a problem and making it worse? Yeah, that's often a problem. Any other thoughts? If you were going to say no, I'd love to, but I don't have a triplicate. Yes, that is one that we do see. And, you know, I mean, the implied question there is, why would a person make that choice not to carry a triplicate prescription pad? I suspect that in a lot of cases, it does have to do with just uncertainty and really just not knowing what to do next. And so feeling like maybe the safest thing is to not take this patient on. Next slide. The problem with not taking this patient on is that there are few alternatives open to this patient if you don't take them on. So it would be totally reasonable to look at this hydromorphone 12 milligrams immediate release 4 times a day and go, that's terrible. I hope that is your reaction. That's not a great plan for managing chronic low back pain. One of the risks is that Robin goes out and finds somebody who doesn't think that's a bad plan. And to me, that's as much of a risk as anything else. But then, of course, the other problem is that there are all kinds of non-medical places where Robin can find opioids if they're going into withdrawal and they're very uncomfortable. There are places that they can buy opioids, and the current context means that that's an unsafe option. They could die the very first time they do that. So just to reassure you, just right off the bat, the CPSA's position on this is they would like you to take Robin on as a patient, and you don't necessarily have to make any changes at all. Just implement some safe prescribing practices. So I'm kind of steering you in the direction on this slide of some ways that you can determine what those safe prescribing practices are. The standard of care is just like a page and a half on the CPSA website. It's a pretty quick read, and literally that is all they expect of you. And it's things like take a history. Make sure the patient understands all of the options, monitor the patient closely. It's those kind of very straightforward kind of motherhood things. The CME office at the U of C, we have a course that's called Wide Prescribing and Deprescribing that has a whole bunch of free modules that you can go and look at that outline really what does safe opioid prescribing look like. And then there's a link here to the Canadian Opioid Guideline, which gives you the full meal deal, every bit of information that you would want to have around what safe prescribing looks like. Next slide. The other thing that I must highlight is that if you are not a member of the Collaborative Mentorship Network, that is a really good way to have some support and some backup if you are taking on a patient like Robin and you feel agreeably about it. That's a group that you can go to and ask some questions or get matched up with a mentor who can give you some tips about what to do if you get into trouble. So some good options there. Next slide. So let's say you do decide to take Robin on as a patient. Question often comes up, okay, are we going to talk about tapering? And sometimes somebody would take Robin on as a patient and say, I will do this, but only on the condition that you taper your medications. And so that may not be the best approach depending on where Robin's at. Next slide there. So basically, rapid changes, and particularly rapid changes that the patient's not on board with, are very rarely needed. And they're potentially very dangerous, like I've said. So one thing about talking about tapering is we want to be clear that as much as you can be clear, as much as it's possible to be clear that the patient doesn't have an opioid use disorder. Because first line treatment for that would not be tapering, it would be opioid agonist therapy. I wish we had a little electrode we could put in the brain that says opioid use disorder or not opioid use disorder, but we don't. You have to do the best you can to establish that there aren't cravings, loss of control, things that lead you to think that this is an opioid use disorder. So that's the first thing. If you determine that that is not what's going on with Robin, then there's all kinds of reasons why Robin might have gone for 11 years on opioids and not decided to make any changes. And we can't assume, it's not, opioid use disorder isn't implied by virtue of the very fact that Robin's been on opioids for 12 years. So we need to figure out what their stage of change is before we start talking about tapering. So next slide. If you were at Sasha's very excellent presentation last time, you will have seen this graphic talking about stages of change. And if you were not at Sasha's very excellent session, there is a recording that you can access and have a look at it, because that is really, and I gave you the heads up if you were at that session to pay very close attention, because it was going to come back in this session. Because it's really important to, we really fundamentally, in order to know where to go with Robin, you have to know what their stage of change is. So next slide, if you advance, we will get a little circle there. So we tend to assume that anybody who has not made changes to their opioids must be pre-contemplative. Or, if I've mentioned to you that you should taper and you haven't tapered, you must be pre-contemplative, and that's not necessarily true. So pre-contemplative, really no intention of changing, no ambivalence whatsoever, firmly convinced staying the same is the right way to go. That's what pre-contemplative looks like. So how do we figure that out? Next slide. I use the readiness ruler, which comes out of the motivational interviewing literature. And so how important is it to you to make a change in your opioid now, 0 to 10? So if the answer is 0, then they are pre-contemplative. It's very straightforward. So if the answer is 0, we're not going to push the idea of tapering. There's pretty good evidence that if somebody is pre-contemplative and you keep hammering away at all the reasons why they need to change, that actually makes them less likely to change, because they spend all their time rehearsing ways of telling you that they need to stay the same. And if you heard Sasha last time, what we want in a patient who's moving towards a change is to encourage them to think about and talk about change, not think about and talk about staying the same. And if they're pre-contemplative and you're constantly hammering away at why they need to stop, all they do is think about the reasons for staying the same. Just where's a rut in the road? So we just do safe prescribing. We just say to the patient, okay, we're going to carry on the way we are. If you are ever interested in making a change, come talk to me. I'm happy to talk to you about it. And just heads up, every once in a while, maybe every 6 months, maybe once a year, I'm going to check back with you and see if your stage of change has changed and if you're interested in talking about anything different. Next slide. So really, if you think about the pre-contemplative patient, they are hanging on by 3 fingers to one handhold, and you're asking them to pry their fingers off of that one handhold. And it's not going to be successful. It's going to be bad for both of you if you try to force them to make that change. So we're really just going to try to give them as many supports as possible in other ways, so that at some point in the future, it might occur to them that it might be okay to let go of that one handhold. Next slide. So the contemplative stage is the stage where the magic happens when it comes to motivational interviewing. So this is where we use MI. You're not using that in a patient in the pre-contemplative stage, but somebody who's contemplative, by definition, there is some part of them that wants to make a change and some part of them that doesn't want to make a change. And those 2 bits are at war, and for the moment, they're not making a change, but there's some part of them that's thinking that maybe at some point they might like to. Again, we tend to assume that if the patient hasn't made a change, they must be pre-contemplative, but very often, I think my experience with this is more patients are contemplative than we think, and they're just terrified. And so they're thinking there's reasons why they would like to make a change, but they're just scared to do it. So So again, we might use the readiness ruler and say, how important is it to you to make that change? And if it's anything other than 0, then they're contemplative. And then we're going to talk about confidence, and we're going to talk about some other things. We're going to start to use all of those motivational interviewing strategies to try to move them in the direction of preparation. So, so at this stage, we're not planning a taper. If you start planning when they're in the contemplative stage, you're probably going to scare them off. So motivational interviewing is the strategy that you're using in this category. Next slide. So you might remember Sasha had a slide on eliciting change talk. So again, getting the person talking and thinking about taking the change road instead of the stay the same road. So one of the really simple questions, if you're using the readiness ruler and they're rating the importance of changing their opioid at a 3 out of 10, tell me about why it's not a 0. Why is it a 3 instead of a 0? And then you get them telling you, explaining to you, articulating, saying out loud what it is that they think needs to be changed. So all by itself, that's motivational interviewing. One of the questions that I have used a lot, and this kind of evolved out of helping a patient to explore their ambivalence around the opioid. What are the reasons why you continue taking it? What are the reasons not to? But it sort of, for me, evolved to, at one visit when I see them, I will give them some homework, go away and make a list for me of all the things that you love about hydromorphone. And I would say that 90% of the time they come back and say, well, love isn't exactly the right word. I maybe wouldn't use that word. And then again, they're talking about maybe the things that they don't love. It's my sneaky way of sneaking that in. And then for the next time I see them, their homework is go away and make a list. If you could wave a magic wand to change anything at all that you could about the hydromorphone, what would it be? So if you put it in that sort of magical realm, it makes it a little bit less threatening. You're not making a pro-con list. You're just saying, if you could wave a magic wand and anything at all would be different about it, what would it be? And they often do come back with a list of some things that they really have been thinking about that they don't really love about the hydromorphone. The other thing is, if you know that Robin quit smoking 20 years ago, tell me what it was like to quit smoking. So getting them talking about a change that they have successfully made in the past builds their confidence that they can make another change, sort of draws the parallel that they might be able to make other changes in the same way. Depending on the patient, depending on what you know about them, you might say, what worries you about still being on the hydromorphone 5 years from now or 10 years from now? Especially as people start to get older, they start to maybe have some concerns about how that's going to affect them in the future. And again, putting it in the future state makes it a little bit less threatening. So, why would you want to make a change by 2026? Again, steers them in the direction of more of that talking about change, but in a less threatening way than let's taper your opioid starting next week. Next slide. So preparation stage, once the patient is at that preparation stage, that people sort of have different, people will say, well, once they're at a 7, they're in the preparation stage. I'm not sure there's necessarily a hard and fast readiness ruler score that tells you that they're ready. For me, it's just like, do you feel like you're ready to set a date when we could aim for tapering? If so, then probably they're in that preparation stage. Once they get to the preparation stage, this is actually super easy. This could probably be done by AI, and it's a really easy task once they're at that stage. The art is getting from contemplation to preparation. Next slide. So one of the resources that I'm going to give you at the end is a link to find our tapering template. And one of the things that is at the very top of that document is documenting the patient's goals for tapering. So what is important to them about making this change, because if it is a little bumpy in some ways, we want to be able to go back. We want everybody on the team who is seeing that patient to be able to go back to remind them of what the important things were. What's your North Star? What are the reasons why you're tapering? And then we're going to go through and talk about all of the things that could potentially be thrown out of whack temporarily by a taper, like sleep, pain, mood, appetite, bowels. We're going to talk about timing. If you're an accountant, we're probably not going to start tapering your opioids in April, stuff like that. And then we're going to set up a plan for how, when we're going to make those changes. Typically slower than the textbook says is basically what I'll say. Sometimes really, really slow. My goal is that the patient notices nothing in terms of tapering. The first few steps, they should notice nothing at all. Next slide. There is not a huge weight of evidence on opioid tapering, but I will tell you the Cole's notes to this is that in the trials where patients have more control over how much of a step they make and when, the patients tend to make bigger reductions in dose that are more sustained. When you randomize people to tapering or not tapering, and then you give them an algorithm for how they have to taper, those trials tend to be negative and the patients do worse at the end of the day. Next slide. So some resources here, I've mentioned a couple of them. The Center for Effective Practice tapering template initially looks very overwhelming. You will open it up and go, but it really has everything you could possibly want or need when it comes to tapering. And then I have given much longer versions of this talk on 2 occasions to the PCN pain rounds. So the links are there if you want to look at the longer version of these things. And I tried to leave at least 5 minutes for questions. Did I do that? Ish.
You're almost perfectly on time, Laurie. So yeah, please feel free to ask some questions to Laurie while we have her, and we have about 5 minutes. So.
So I can't stand to have any empty airspace. This is a hint I got from Christy Sutherland, who does a lot of addiction work in Vancouver. But it struck me when she said it, and you said it again at the beginning of your talk, Laurie, is that patients come in worried you're not going to prescribe and they don't hear you. And so they spend their whole time planning how they're going to get their medications because they're afraid. And she said, I just hand the prescription and say, I'm not stopping. Now I want you to, let's talk. And it was so effective. And I was like, oh, I wish I had known that like 20 years ago. But yeah, I don't know. It was such a simple strategy. And you could bring people back in a couple of weeks. They knew that, yeah, you're just trying to assess where they're at. So yeah, that's my handy hit.
That is exactly it. And if I know that ahead of time that the patient I'm meeting is really anxious about their opioids, that's the first thing out of my mouth. We're not talking about stopping your opioids today. For now, I'm not going to suggest any changes at all to your opioids. Let's talk about the rest of your plan.
Yeah, I agree. And then the second thing is, if they're pre-contemplative, don't keep hammering at it, and do safe prescribing. Yeah, that's yeah, super helpful. Thank you.
How long is the wait between visits with patients? Like in terms of my motivational interviewing questions, Tina?
Yes, that's it. I was just wondering about how you follow up. And
yeah, I mean, ideally, I would like to see them in a couple of weeks, 2 or 3 weeks, and talk about the answer to their questions. For me, in my context, that's not usually realistic. So it's more like, for me, it's usually a couple of months, or it's a strategy that I'm going to use in concert with our clinic nurse or pharmacist, or somebody else is going to call you up and is going to chat with you about the answers to these questions. We're all doing motivational interviewing all the time.
I just wanted to ask Laurie where your lovely sketches on your slides are really nice.
Thank you. I will pass that on to my sister, who's the artist. I've commissioned all these drawings from my sister and paid for them so that I can legitimately say I own them and have the copyright.
They're beautiful. So anyway, I'll end this session then just by saying thank you very much for presenting today, and encourage all of you to share your thoughts in the evaluation that we put in our chat for everyone to fill out, and to invite you again to come to our next session, which will be on May 18th. And we'll hear from a speaker about migraine and new therapies, and all you have to do is register. So, and also think about submitting a case if you have something that you know is kind of weighing on your mind and you'd like to present it to our hub team and the audience. We'd love to hear from you. There is a case presentation form that you can fill out, and again, the link is here, but you also find that on our webpage. And we'll just go to our last slide. Again, just a pitch for, and I love that Lori shout out to us during her presentation about getting some support from the Collaborative Mentorship Network. We are here for you whenever you need anything, and your participation with us is up to you in terms of how you'd like to participate. We have opportunities to be mentored or to be a mentor. So again, you can just go to our website to check us out. And finally, we are also just pitching our Pain BC courses again, just to let you know that we have these courses available for anyone who's a member of our CMN. These are completely free for our members. And so again, if you want to join us, we can get you set up with those. And I think we have one last slide. I'm not sure.
That's it. That's all.
That's
We're
it.
leaving you
Okay.
hanging. The Pain
Leaving
BC
you hanging
courses.
today, but thank you all so much for joining us, and we hope to see you next in 2 weeks, and take care of yourselves, and may the 4th be with you.